Hello everyone, a very good evening. Uh, I believe we are the first one to come up with this video-based question series. So, in the recent FMG exam, a lot of students were just worried and panicked after the surprise too many video-based questions, right? I people used to drop in one or two video-based questions, but this time in FMG, recent FMG exam, there were a lot of video-based questions. And just after that, NB released the notification of your NEET PG exam, and in that, they changed the number of questions from 200 now 180 questions. Though the time is same 3.5 hours, so lesser number of questions. So I believe they're going to be longer questions, more extensive clinical stems, and you can expect a lot of image-based questions, video-based questions. So this is our initiative from our side to introduce these video-based questions to accustom you to how to easily navigate through that, what type of videos they can ask. Here we are going to discuss 10 questions, and after that I'm going to show a compilation of videos of movement disorders, which I believe would be covered very extensively in medicine. But from the pediatrics point of view, what are the pointers that you need to take care of? All of those I'm going to discuss, right? So, if without further ado, let's just begin, right? So, I'm going to show the video first, then the clinical stem and the options, right? So, look at this first video. Can you notice this infant? He's holding a furniture, right? So what is this milestone? This is stand with support, right? He's holding the furniture and standing. So this infant is observed holding onto a furniture. Which of the following milestones is likely present to be present at this age? Mature pincer grasp, immature pincer grasp, walk with one hand held, speak two words sentences, right? So firstly, when does this milestone appears? When does this milestone appears? This milestone, we all understand this is stand with support. And the stand with support comes at 9 months of age, right? 9 months of age. So they are asking at which age this will be there. So mature pincer grasp, you all know, 12 months. Immature comes at 9 months. Walks with one hand held again at 12 months. Speak two word sentences at 24 months or 2 years of age. Right? So the stand with support comes at 9 months. So the milestone that collaborates with 9 months here is immature pincer grasp. So they're going to drop in such integrated questions, right? Giving you milestone, asking what other milestones would be seen at this particular age, or could ask which next milestone could be there, right? So observe the video carefully, which milestone is this. So moving to the next question, I've dropped this animation over my Instagram also. Can you notice this girl child? A very typical movement is happening over here. A stereotypical midline hand washing or hand wringing like movement, right? So let's move to the clinical stem. We have an 18-month-old girl who was previously meeting all the developmental milestones, now presents with loss of purposeful hand movements and development of repetitive midline hand movements. Genetic analysis is likely to reveal a mutation in which of the following gene? Firstly, what is this? This girl child previously had normal milestones, but now there is loss of previously acquired milestones. Loss of previously acquired milestones. So what is this? When a child loses a previously acquired milestones, we label it as neuroregression. So along with the neuroregression, what is there? There is a stereotypical hand movement, right? A stereotypical hand movement, hand wringing movement. So whenever you see this neuroregression along with the stereotypical midline hand wringing or hand washing like movements, this is nothing but Rett syndrome, a cause of acquired microcephaly, right? So look for these pointers. Firstly, neuroregression, stereotypies, and third, acquired microcephaly, right? So a clinical stem will tell you these three things: neuroregression, that the child has lost the previously acquired milestone; second, stereotypical hand movement with as seen in the video, right? As seen in this video, can you notice the stereotypical midline hand wringing movements? and acquired microcephaly. That means now the head size of the child will be into a halt. The head size will appear smaller, right? So this is nothing but Rett syndrome, and in Rett syndrome the most common mutation is in MECP2 gene. MECP2 gene, and predominantly female children are affected, right? Okay, so this is about Rett syndrome. We'll come back to this question and ask about other options also, but let's first just cover these 10 questions. We'll come back. Okay, so moving to the next video. Look at this child. What can you notice? A sudden flexion happening in the trunk, neck, right? So you have a 6-month-old infant who presents with these sudden, brief, symmetric contractions of the trunk and limbs, and they are occurring in clusters. The EEG shows a highly disorganized pattern with high voltage, slow waves, and spikes. What is the drug of choice for this condition? Ethosuximide, vigabatrin, sodium valproate, adrenocorticotropic hormone. What do you think is the correct answer over here? What is this? What is this condition? Firstly, tell me. An infant, 6-month-old infant, there are brief, sudden symmetric contractions of the neck, trunk, and limbs, as you can see. And these are happening in clusters. That means they're happening again and again in groups. The EEG also shows a very chaotic pattern, high voltage, slow waves, and spikes. What is the drug of choice of this condition? What is this? No, this is not absence seizure. This is a typical case scenario of West syndrome. West syndrome. Yes, exactly. This was infantile spasm. This, whatever this child is doing, the sudden flexion, this is infantile spasm. And whenever you see this infantile spasm in clusters, that means happening again and again in groups, in clusters. Along with that, if you notice on EEG, there is a chaotic pattern. That means hypsarrhythmia is there. Chaotic pattern is there. Along with that, there is again neuro developmental regression. That means the child will lose the previously acquired milestone. Whenever you see this triad, this is nothing but West syndrome. And in West syndrome, what is the drug of choice? If you look at the recent guide, they say the drug of choice is steroids or ACTH or ACTH. Here in the option, you can see ACTH only, right? Exam tip from my side: if the question stem gives both steroid as well as ACTH, go for ACTH, because in AIMS they prefer giving steroids, right? So prefer steroids. If the one of the options is steroids and other options is ACTH, do not get confused, because both are the drug of choice. But in a country like India, steroids are relatively cheaper, oral, and are non-inferior to ACTH, so we prefer steroids in most of the cases. And also in AIMS they prefer giving steroids. So if one of the options is steroids and other option is ACTH, do not get confused, mark steroids. Otherwise, choose the best option over here, right? So this is ACTH, option D. Vigabatrin, remember, is the drug of choice for West syndrome in patients with tuberous sclerosis. Tuberous sclerosis, right? Let's understand this West syndrome. I told you there is a triad: seizures, infantile spasm happening in cluster, developmental regression, and EEG has hypsarrhythmia. That means a high voltage chaotic pattern, as if some child has scribbled over the EEG print, right? Remember, this West syndrome can be either idiopathic or cryptogenic when the underlying brain abnormality is not there. But when the underlying brain abnormality is there, this is known as symptomatic West syndrome, as in tuberous sclerosis, right? In tuberous sclerosis, you have subcortical tubers, and in tuberous sclerosis, the drug of choice, remember, is vigabatrin. Okay, so this was about West syndrome. Let's move to the next question. Observe this child now. Right, this child is sitting in the emergency department. Can you notice the drooling of saliva? How is his breathing very rapidly? Seems in distress, has a toxic look, right? This child looks absolutely sick to me. Look how the child is leaning forward with taking support of the forearms, right? What is this? What is this? Can you tell me this posture? This is a tripod posture with the toxic looking child presented with high grade fever. There's drooling of saliva. So what is this? This is a 4-year-old child that presented to your emergency department with high grade fever, sore throat, drooling. The child is leaning forward as we just saw with extended neck. What would be the most appropriate next step? We have option A as examine the throat with trunk depressor. Option B, administer nebulized epinephrine. Option C, prepare for urgent intubation. Option D, obtain a lateral neck x-ray. What do you think? A lot of you have given the diagnosis, yes, this is acute epiglottitis. What would be the next step? Next appropriate step in this case, whenever you see a child looking like this, what would be the next appropriate step according to you? What is the next step? What are you going to do? Are you going to examine the throat? Are you going to give epinephrine nebulization? Or are you going to prepare for urgent intubation, obtain a lateral neck x-ray? Okay, so Pradeep is saying D, get an x-ray done. Vishal is also saying get D X-ray done. Jishan is saying that go for urgent intubation. So Jishan, you are right. We prepare for urgent intubation. It is a emergency scenario. Remember, acute epiglottitis emergency scenario. We have to first focus on A, B, C. So securing the airway is the first most thing. So prepare for urgent intubation. This is a very toxic looking child, right? So let's revise a few things about acute epiglottitis. The age group, 1 to 3 years of age. Most common causative agent is a bacteria, Haemophilus influenza type B. How will the child look come up to you? The child is going to have a high grade fever, will look very toxic, muffled voice, this tripod position, drooling of saliva, right? Severe respiratory distress. The x-ray, yes, shows thumb sign. If you look at the normal epiglottis, it looks like this, but swollen over here, right? You can notice the swollen epiglottis. This is known as the thumb sign, right? So this is about nothing epiglottitis, right? Vitals are mentioned, Pradeep. They have given that the child has a high grade fever, sore throat, and can you look in the image how the child is sitting, have a typical toxic look? These are the enough clues. They don't need to give you the heart rate, the pulse rate. They have mentioned high grade fever, drooling, sitting like this, leaning like this. Can you notice how the child is breathing? Visibly, the child looks in discomfort, severe respiratory distress. They are focused on the chest also. So this is nothing but acute epiglottitis, and the next step is going to be ABC, airway, breathing, circulation. So urgent intubation, option C is the correct answer over here, right? Moving to the next video. Look at this. I asked this girl child to take out the tongue, protrude the tongue, and I can notice this. What is this? The tongue is coming in, going back, coming out, going back, coming out, going back. What is this? Can you tell me? What is this? What is this sign called as? What is this sign? This is darting tongue sign. And where do you see this darting tongue sign? Remember motor impersistence. This is a hallmark of Chorea conditions, right? Motor impersistence. So what happens in motor impersistence? So you understand chorea is an involuntary movement. So whenever this violent involuntary movement happens, so they sometimes disrupt your normal movements, normal voluntary actions. So that's why you see this darting tongue, jack in box phenomena, and also the supinator sign you see, spooning you see. All of these things are associated with chorea. So coming to the question, during the physical examination, the child is asked to protrude their tongue, but it repeatedly retracts and darts in and out. This is darting sign. This is associated with which condition? You have tardive dyskinesia, Wilson's disease, Sydenham chorea, Huntington disease. So the correct answer here is Sydenham chorea, right? Sydenham chorea. Though Huntington's disease is a confusion over here, but remember Huntington's disease in childhood does not typically present with the chorea-like movements. It initially has those bradykinesia, so the most appropriate answer here is going to be Sydenham's chorea. Okay, so moving to the next video. Look at this child. Child is looking into the mirror, playing with their own reflection, smiling at it, right? This is what is happening. Can you appreciate? Right? So the question here is they're asking at which age the child enjoys looking at the mirror, smiles, and try to reach their own reflection without yet realizing that it is themselves. Essentially, the examiner is trying to test whether you know when does mirror play comes. Mirror play. So when does mirror play comes? Yes, Vishal, you are right. Mirror play comes at 6 months of age, option A, 6 months of age, right? So very typical milestones, are very frequently tested one. This is mirror play. Moving to the next question. Look at this scenario, what is happening over here? Look at this animation, what is happening? So mother denied the mobile phone, he turned blue, right? So this happened. So what is this? What is this? The child was asking for mobile phone. Mother denied giving iPhone. He cried, turned blue, then regained back his consciousness, right? So a 2-year-old boy becomes angry after his mother denies giving him mobile phone, cries vigorously, then suddenly stops breathing and turns blue before losing consciousness for a very brief duration. He turns back normal after a few seconds without any confusion, without any drowsiness, which is of the following is most likely to be associated with this condition: temporal lobe epilepsy, GERD, long QT syndrome, iron deficiency anemia. Yes. So what was this condition in the first place? Yes, this was a breath holding spell, a cyanotic breath holding spell, right? It is a reflex event. It is not a temper tantrum of some thought. This is a reflex event after frustration, anger, prolonged crying. The child immature reflex system. What it does, there will be apnea after a prolonged expiration. That's why the child turns blue, faints. There is an exaggerated vagal response, and as soon as the child loses the consciousness, the respiratory system takes over. He comes breathing starts again, he turns back normal. There is no post-ictal phase over here. So this is nothing but cyanotic breath holding spell, and it is very closely associated with iron deficiency. So iron deficiency anemia is the correct answer over here. Hitesh is right. Jishan is again right. So let's look at the other options here also. So temporal lobe epilepsy. Temporal lobe epilepsy can present in this way, but in epilepsy, remember, whenever true seizures are happening, there is going to be a post-ictal phase. And often seizures do not have this emotional trigger, right? So no trigger in cases of epilepsy, and there is often a post-ictal phase, which we do not see in this question. Then comes GERD. In GERD, what do you see? In GERD, we see something known as Sandifer syndrome, where the child will be having this opisthotonous posturing, and again, there is a trigger, that is food intake, not mentioned in this question. Long QT syndrome sometimes presents with brief lapse of consciousness, right? More goes in the favor of absent seizure-like situation, and also sometimes in this situation, if you are worried about long QT syndrome, there is a family history, then we go for ECG, right? But that is reserved for some cases where there is some family history or you have a suspicion per se of this long QT syndrome. The most appropriate answer here is going to be iron deficiency anemia, right? So let's discuss something more about this breath holding spell. I told you it is a reflex event due to immature autonomic nervous system, exaggerated vagal responses there. The age group in which you see is 6 months to 5 year of age. Slowly the child, as the child grows, no longer these breath holding spells are going to happen. What happens over here? In cry, frustration, pain, the child will hold the breath in full expiration and either turn blue, that is a cyanotic breath holding spell, or or pale, that is a pallid breath holding spell. Just reassure the parents about this condition, that this is a developmental condition, behavioral disorder, developmental behavior thing. It will sooner or later the child will outgrow this. Just at this point of time, you have to counsel the parents that whenever this such episode happens, make the child lie down on a flat surface where there is no harmful thing around, right, and a safe flat surface. Do not lift the child up or shake the baby during this episode, because lifting the child up can actually further decrease the blood flow to the brain. And also do not shake or start giving CPR to this child, right? Just turn the baby sideways, so as to not let the baby aspirate something if there is anything in the mouth. Differential diagnosis definitely are seizures, cardiac arrhythmias, long QT syndrome. Whenever you have a suspicion for that, you can go ahead with evaluation. With iron deficiency anemia, apart from breath holding spell, you have to remember three more conditions. First is pica. Second is restless leg syndrome. Third is temper tantrums, right? So these are the clinical associations with iron deficiency anemia. Whenever you encounter any of these conditions or the examiner tries to test you the associations with iron deficiency anemia, you should remember these four conditions: pica, restless leg syndrome, temper tantrums, and breath holding spells, right? So now let's see the next video. Can you notice how the nursing staff is feeding the baby right now? With a spoon, a steel spoon, a spouted steel spoon, the traditional Paladai, right? This is Paladai feeding. So let's see what the examiner is trying to ask from this video. So examiner has given you a clinical scenario that a preterm male infant who is born at 30 weeks of gestation is now on day 10 in life in NICU. He has been receiving gavage feeding, that means OG feeding or NG feeding, and is tolerated full volumes. His current weight is 1.35 kg. On examination today, he shows stable vitals, good spontaneous activity, has begun exhibiting coordinated rooting and sucking behaviors during care circles. The clinical team wants to transition him to oral feeds using a traditional Paladai as shown in the video. Now they are asking, what is the absolute minimum gestation age or post-menstrual age the infant should typically reach before safely initiating the Paladai feeding, and why? Right? So they are asking two things. When usually we start giving Paladai feeds, and second, why do we start at that particular point? So option A says that we give at 30 weeks because the Paladai bypasses the need for sucking reflex by then. Option B says 32 weeks because sucking and swallowing coordination mature at this time. 34 weeks because the protective cuff reflex is absent prior to this age. And lastly, 36 weeks because a Paladai requires active coordinated lip seals like breastfeeding. What do you think is the correct answer over here? What do you think is the correct answer over here? The Paladai feeding. When do you transition? What all maturation, neuromuscular maturation should be there to start this feeding? So Hitesh is saying A, that 30 weeks. Shweta is saying C, 34 weeks. Hitesh is again confused between A and B. Shubham is saying C. So let's revise the concepts, the modes of nutrition. So when the child is very small, less than 28 weeks, what happens? The gut is not mature. So gut motility is absent. So you cannot give anything into the gut. I cannot give enteral nutrition. I have to give parenteral nutrition through IV line, right? So we give total parenteral nutrition before that. In between 28 to 31 weeks, what happens? The gut motility now starts. Also, the reflexes that you need for proper feeding, rooting, sucking, swallowing, they are absent. But gut motility has been fine now. Gut motility, gut maturity is achieved. So what can I do? I can place either an NG tube or an OG tube and directly transfer the milk into my gut, right? At 32 to 34 weeks, now the reflexes, rooting reflex, swallowing reflex, sucking reflex, they all appear. So I can start giving katori spoon feeding. After 34 weeks, a proper coordination and maturation of this reflexes happen, so I can directly start breastfeeding. So the correct answer is nothing but option B, that 32 weeks, because the sucking, swallowing reflex are now there. So remember, Hitesh, you read it today only, but you forgot. It's very easy. Remember these blocks: less than 28, 28 to 31, 32 to 34, and after 34, right? These blocks you should remember. Initially we give total parenteral, then you start to OG-NG feeding, then you give Paladai, and lastly you start with breastfeeding, right? So these are the approximate gestational age. According to the maturity of the baby, we can transition. Like in this scenario, they have given you a 30-week child. This child is not yet 32 weeks. He is day 10 of life, right? Not yet 32 weeks. He is somewhat around 31 weeks and 3 days. But because he is showing us good activity, spontaneous activity, rooting, sucking behavior, so in this case we can try giving Paladai feeds, right? So these are the minimum gestation age by which this maturity comes, but depending upon the child, in practical scenarios we transition early if the child is showing good activity, showing these coordinated rooting, sucking behaviors, right? So this is about your Paladai feeding. Let's move to this next situation. Can you notice how this mother is holding this baby, right? Can you notice how the mother is holding this baby? What is this? How is the mother caring for this baby? Is there a specific name to this care? Anyone? So the mother has the baby over her chest, skin to skin contact, and she has wrapped her gown over the baby. This is nothing but kangaroo mother care. Kangaroo mother care. Right? Shubham is right. This is kangaroo mother care. So let's look at the question what the examiner is trying to ask us. So we have a low birth weight infant who was born at 33 weeks of gestation, weighing 1.6 kgs. That means it was a low birth weight baby. This child is admitted to a level 2 special newborn care unit. The baby is stable on room air, no respiratory distress is there. The pediatric resident is counseling the mother regarding the initiation of KMC. Which of the following instructions provided by the resident is completely accurate according to standard WHO and national guidelines? Option A, KMC should only be provided by the biological mother to prevent cross contamination. Is that true or false? This is false. Anyone can give this KMC, right? Father can also give, grandmother can also give. Just the mother is not the correct statement. Moving to the second option, to be effective, each session must last for a minimum interrupted duration of 1 hour. This is true. Minimum duration 1 hour, maximum can be any much, right? Throughout the day also mother can stay like that with the baby. So minimum uninterrupted 1 hour. Correct. Option C says KMC can be safely discontinued as the infant reaches a chronological age of 28 days, which is actually a false statement. KMC can be continued as long as the baby is comfortable in that position. Once the baby denies that position, then at that time it can be discontinued, right? So you allow KMC as long as the baby wants KMC. So this is again a false statement. Option D, during KMC, the baby should be kept fully clothed with front opening sweater to retain the body heat. This is again a wrong statement. Wrong statement. Baby should not be fully clothed. The baby's front zip should be open, front opening sweater. There should be skin to skin contact. You can keep a cap over the head, but fully clothed baby, not a correct guideline. So the correct answer here is option B. Hitesh is right, option B, right? So let's move to the next question. What is happening over here? They're giving breaths through the ambu bag. breast through the ambu bag, right? So the examiner is giving you this scenario. A term male neonate is born via emergency low LSCS, lower segment cesarean section for fetal distress. At birth, the baby is apneic and limp. Initial steps of resuscitation, that is drying, warming, positioning, suctioning, are performed. At 60 seconds of life, the heart rate is 78 beats per minute and the infant remains apneic. Which of the following represents the most immediate action, including the correct ventilation rate and pressure using an ambu bag? Right. So a lot of things the examiner has given you and the correct things the examiner has given us. Right. So they told us that at birth the child was not breathing, the child was limp. So you started with initial steps of resuscitation, and now 1 minute has happened. We all know 1 minute is important. It is a golden 1 minute. Within this, if positive pressure ventilation should be started. So they have given us that the child after initial steps is still apneic, heart rate is less than 100 at 78 beats per minute. So we have to start positive pressure ventilation using this ambu bag. So let's see how we can give this ambu bag. Initially we focus on just ventilation. For good whole 30 seconds of effective positive pressure ventilation, you have to give this, right? So let's start. The first option says starts chest compressions immediately, which is a wrong statement, false statement. Firstly, you give effective positive pressure ventilation. If despite that the heart rate is less than 60, then we go for chest compressions. Second option says that initiate positive pressure ventilation at a rate of 40 to 60 breaths per minute, aiming for a peak initial positive inspiratory pressure 20 to 25 centimeters of water, which is a true statement. Third says initiate PPV at a rate of 80 to 100 breaths per minute, which is false. The target is 40 to 60 breaths. And the last option says administer free flow oxygen via face mask held closely to the baby's face for 30 seconds, which is not recommended. We start with positive pressure ventilation. So the correct answer here is option B. Everyone over here is right. The Pali is right. Jack Rose is right. This is option B. Initiate positive pressure ventilation 40 to 60 breaths per minute, aiming for PIP 20 to 25, right? So with that, we cover the 10 questions. Now I'm going to show you some of the videos from my end which are important for your exam, right? So firstly, look at this. In this video, I'm going to show you 3 kids. This is something that we have discussed earlier also. So look at this first child, baby A. Very happy looking at the father. He gets very excited and do something like this, as if a shivering movement, right? A shivering, a tightening movement, as if someone has dropped cold water on his back. What is this? Is this normal or abnormal? Do you find this a normal thing or abnormal thing? This was a normal thing. This was shuddering spells. This was a normal thing, right? So this is a normal thing. This is shuddering spells, right? So this is a developmental variation. You don't need to worry about this. This is shuddering spells. If the child's development seems normal and out of excitement, the child is doing like this. This is shuddering spell, which is normal. Now look at this child B. Child B. Observe this child closely. What was that? Infantile spasm. And look here, this is the child of Rett syndrome. Here, infantile spasm happen in clusters. Can you notice back to back this is happening? Back to back this is happening. This is a 2-minute long video, and this entire 2 minutes the child is doing this cluster infantile spasms only. So whenever infantile spasms are present in clusters, this is nothing but Rett syndrome. Rett syndrome. Right? Rett syndrome. Right? So with that, now the last video, that is movement disorders. So movement disorders, whenever we are talking about movement disorder, you should know how to precisely define the abnormal movements. And once you know how to define abnormal movement, you will easily pick up what this movement is, right? So let's start with the very first movement, that is ethetosis. What are ethetosis? Ethetosis is slow distal breathing movements. Look at this child doing like this, right? So usually if you see a distal movement and it is a very slow breathing movement, this is ethetosis. Right? This is ethetosis. So this child has ethetosis with us. Right? This is ethetosis. Then you have chorea. What is chorea? Chorea is an involuntary semi-purposeful movements. So these are dance-like movement, very unpredictable, large joint movement, proximal movement, right? Flowing as if it movement is transferring from one limb to the other, very unpredictable, right? And sometimes because these are unpredictable movements, child try to make purpose of that movement. So for example, if there is a jerk like this, child will try to comb his hair like that, right, to make it into some purpose, semi-purposeful movement. So it can involve both upper limb and lower limb. Moving to tics. Tics are just sudden, abrupt, repetitive movements. They can be vocal tics or they can be motor tics. You can notice over here, these are motor tics. The child is going like that. And sometimes you have vocal tics also. In vocal tics, the child will produce some sounds or some slangs the child could come out of with. The important point in tics is there is a premonitory urge. That means the child will feel an urge to do that tick, right? And these are suppressible also. These movements are, these tics are suppressible also. These are repetitive pattern movements. Every time they will be happening uh, with the same pattern. Then you have myoclonus. Whenever you hear the word myoclonus, remember shock-like contractions, as if the child has started shock-like contractions. It could be a positive myoclonus, negative myoclonus. Positive means you will actually appreciate a movement, abnormal movement. Negative means whatever the child is doing, that gets halted for some time. So this is myoclonus, right? So if it is elicited by sensory stimulus, it is known as reflex myoclonus. If by action, it is known as action myoclonus. Then you have stereotypies. We have discussed the stereotypies in Rett syndrome. Similar stereotypies is seen in children with autism spectrum disorder. Also, they do these ringing movements or something like that, right? Again, exacerbated with excitement, stress, or fatigue. This is nothing but stereotypies. Okay, so I know these you have thoroughly discussed in medicine, but from pediatrics point of view, what are the key pointers that you need to know that I have discussed, right? So remember, stereotypies usually in autism and Rett syndrome you see. Now, what are dystonia? Dystonia are abnormal twisting movement. There is such sustained muscle contraction. The child will be like twisting the posture somewhat like that, right? It could be in the upper limb, in the lower limb, and here you see sensory tricks or restiges. What happens in sensory tricks? If you stimulate some other portion of the body, this can be relieved. This dystonia can be relieved, right? So these are dystonia movement. There is simultaneous contraction of the antagonist and agonist muscles. A twisting movement, a random twisting movement are there, right? So this is dystonia. Then you have tremors. These are rhythmic oscillatory movement around a fixed point or plane. So these can be action tremors while doing some action. There could be rest tremors as you see in Parkinson's. There could be intention tremors, which is considered a part of your action tremor only. Once you reach the object, it starts tremor. Balismus are high voltitude large joint movements. They can be they usually occur proximally, so a shoulder movement like that or a movement of the leg as happening in this video. So there are these large joint flinging movements. Balismus is very rare in pediatric population per se. More common movements are choreothototic movements. So this is all about the different movement disorders that we appreciate. So thank you everyone. I hope this video based session helped you to come up to have an idea as to how the examiner can present to you in the exam, right? So expect definitely a longer clinical stem, multiple videos like these. Some of the videos here were animation, some of there were real patient videos. I believe both can happen in the exam. Most likely they are going to throw in real patients, but if you have seen the animation, I know you can pick up that in the real life scenario too. So any doubt regarding any of the questions so far? If there are any, please drop that down in the comment section and I'll be more than happy to cover that. So there is no such questions. I had a request when we were discussing this very first question that please explain the different types of gene disorders over here. So this was the question. Remember the Rett syndrome question? So one of the students were asking, ma'am, please explain all other options too. I told you that will come back. So firstly, we have this FMR1 gene. FMR1 gene we all know is affected in which syndrome? Your Fragile X syndrome, right? Fragile X syndrome. There is CGG repeat expansion. So how will this Fragile X child present to you? With definitely mental retardation, intellectual disability. Then you have ATP7 gene. We all know this is for Wilson's. Wilson's, there is a copper transport defect, and also you see a lot of symptoms. There is Kaiser-Fleischer ring, psychiatric manifestations, wing beating, tremors, affection of the liver. All of those things will come. What is UBE3A gene? This is for Angelman syndrome. Angelman syndrome. You know how Angelman is? What happens in Angelman? There is maternal deletion, genomic imprinting disorder. Here you see a happy puppet, right? Abnormal laughter, ataxia, movement, intellectual disability, right? And MECP we discussed. Rett syndrome, there is a girl child with neuroregression, stereotypical hand movement, and acquired microcephaly, right? So this is all about our video based question series. If there is no doubt, we can end the session now. If there is any doubt, you can still drop that down in the comment section. I'm here online. If not, then we can definitely end up this session. Okay, thank you. Have a good evening. We'll meet some other time. All the best for